Welcome to the monthly podcast presented by JAMA Health Forum. I'm Dr. John Ayanian, the director of the Institute for Healthcare Policy and Innovation at the University of Michigan and the editor of JAMA Health Forum.
And I'm Dr. Melinda Buntin, Bloomberg Distinguished Professor of Health Policy and Economics at Johns Hopkins University and the Deputy Editor of JAMA Health Forum. JAMA Health Forum is a peer-reviewed, open-access online journal focused on health policy, healthcare systems, and population health, and one of 12 specialty journals in the JAMA network. Our podcast each month presents highlights of new content from the journal, including timely interviews with authors of research studies and commentaries. Follow us on jamahealthforum.com, on Apple Podcasts, or wherever you get your multimedia, and on jamanetworkaudio.com.
Our guest author today is Dr. Rachel Prusynski. Dr. Prusynski is Assistant Professor of Rehabilitation Medicine at the University of Washington and a clinical specialist in neurologic physical therapy. She is the lead author of a new study in JAMA Health Forum titled Differences in Home Health Services and Outcomes Between Traditional Medicare and Medicare Advantage, conducted with colleagues at the University of Washington, University of Pittsburgh, and Bayada Home Health Care. Welcome, Dr. Prusynski.
Thank you. Really appreciate being here.
Rachel, your study arose in collaboration with a home health company operating in 19 states. How did you develop this collaboration and how did it enable this study in JAMA Health Forum?
You're right, Melinda. This was kind of a unique and exciting opportunity to establish a collaboration with a health system that came about through a grant from the Learning Health Systems Rehabilitation Research Network. And so we call them LEARN, and they really act as a matchmaker in a way to get health system leaders and rehabilitation researchers together. It's a sort of mutually beneficial relationship. And in this case, Bayada helped drive the research question, and then myself with my mentors helped develop those questions and then wrangle and harness their health systems data and analyze it in potentially a more robust way than would occur in typical business operations. So we're really trying to be able to draw more confident conclusions and create more publishable research from the health system end. And the data that they are able to provide us has some great benefits as researchers that we wouldn't get with data if we were to purchase it from Medicare, for example. So we had access to a lot more recent data. We had access to data across payers. So specifically for this question, that was a really good advantage because it can be expensive and delayed to try to get data from traditional Medicare and Medicare Advantage plans. And so we had it all in one place. And then the final advantage was Bayada has some great standardized systems across payers. So in administrative data sets, for example, you might not have the same information coded for Medicare Advantage versus traditional Medicare patients, but we were really able to leverage the fact that they had all of this really rich medical, clinical, functional, and even social information on their patients because they require those assessments to be completed regardless of who the insurance company is.
Thanks, Rachel, for that introduction. And what were the research gaps that your study was designed to address? And what specific types of data and outcomes did you focus on in this study?
The question was really driven by our health system partner as they were seeing a lot of impacts of Medicare Advantage plans on how they are able to deliver their care. So perhaps it would be a little valuable to back up and kind of talk about why that would be. So as you know, Medicare Advantage these plans are required to provide a home health benefit. And we are focused in home health care with our home health partner. But unlike traditional Medicare, they're private insurance companies who are administering these plans. And if you enroll in a Medicare Advantage plan, Medicare pays that private company sort of a capitated rate to cover all your costs. But if you don't need care or if the insurer can get you a cheaper care, then they get to keep the rest of that Medicare payment as profit. So unlike traditional Medicare, Medicare Advantage plans are allowed to manage some of their costs in a variety of ways. And that is what Bayada was grappling with. So what we're seeing as providers and companies in post-acute care is maybe a lot more prior authorization requirements that traditional Medicare doesn't have. Or Medicare Advantage can limit which providers you can see. So their networks of home health agencies specifically might be more limited. And then multiple studies have started to show that these network restrictions may be leading to Medicare Advantage patients receiving care from lower quality agencies or having longer delays in getting home health care. And part of that is because some of the plans will even set some limits on how often the home health agency can provide you that care. So they could say things, depending on the plan, like you get 3 nursing visits and 3 therapy visits for this 30-day period. And traditional Medicare doesn't have those limitations. So a lot of research has started to look at how these changes in managing home health care can impact the care delivery and outcomes. And other work has shown pretty consistently that compared to traditional Medicare, Medicare Advantage patients have less access to home health care. And if they do get approved for home health, they have shorter episodes of care and fewer nursing visits. But where the gaps come in is really some of the evidence on patient outcomes. So far, that work has been a little bit more mixed. And when you look at outcomes like hospital readmissions, for example, other analyses have shown that maybe Medicare Advantage patients are actually faring better in terms of some of these outcomes like readmissions. But the other gap that we wanted to address is that despite the fact that rehabilitation is such an integral part of home health and visits from physical and occupational therapy actually make up about half of all of home health services that patients receive, there's really much less information about how Medicare Advantage impacts how much therapy patients are getting and then their therapy outcomes. So specifically, we targeted functional improvement in mobility. So how did patients do in home health with getting around, getting in and out of bed, walking around their home, and then their ability to take care of themselves. So there are measures for how much help patients need, even getting dressed, getting in and out of the bathroom, taking care of themselves on a day-to-day basis. So we really wanted to target some of these functional measures that patients really have goals of improving, and that's part of the big reason why they're in home health care to begin with.
Great. So now that you've told us all about your data and your outcomes, what were the main findings of your study? And did any of those findings surprise you?
We were able to look at home health episodes for almost 300,000 patients across a 4-year span as recently as 2022. And I think the first sort of surprising finding was, and some of this is what we know and what we've seen in other studies, but some of it was a little bit surprising, is just how different Medicare Advantage and traditional Medicare patients are. We know that Medicare Advantage patients tend to be younger, racially and ethnically more diverse, and those matched our national trends in our data. But because we had this really rich data on function, cognition, and even support at home, we found that across the board, really, Medicare Advantage patients had less cognitive impairment, fewer falls, they were taking fewer medications, they had less pressure sores. So pretty much everywhere we looked, Medicare Advantage patients were less complicated. But while they were less medically and clinically complicated, they also had fewer social resources. So Medicare Advantage patients are more likely to live alone. They're more likely to live in areas with higher poverty rates, more unemployment, less access to transportation, and they're more likely to live in rural areas. And so when we look at those social factors, those are often skipped in other research looking at outcomes, and especially in home health, and especially for rehabilitation. And when the goal is to improve function and get back to the community, we think it's really important to start incorporating some of these more social constructs into our analyses of outcomes. So that was kind of the first potentially surprising thing. But when we then accounted for those differences in our models to look at differences in utilization and differences in outcomes, we also found that pretty much across the board, Medicare Advantage patients received less care than their traditional Medicare counterparts. So even when adjusting for things like clinical need and social need. So even for patients with the same level of impairment, having a Medicare Advantage plan meant a shorter bout of home health services and fewer visits from nursing, physical therapy, occupational therapy, and speech therapy, and home health aides. So across the board, lower numbers of visits during the home health stays. And they were fairly small differences, but I think it's really important to recognize that those differences were there even when we were comparing apples to apples in terms of all of these similarities between the two groups. And then when we looked at outcomes, we also found that Medicare Advantage patients were less likely to improve in their mobility and their self-care function. And again, there were smaller differences, but even with less functional improvement, Medicare Advantage patients were still more likely to be discharged to the community rather than to an institutional follow-up care. So those were kind of the other surprising findings.
Thanks, Rachel. What are the implications of your study for policymakers and clinicians?
So I really think taking the combination of findings together is really important. So that combination of less functional improvement but more community discharge is really where we start to get concerned. So we're worried about the fact that compared to traditional Medicare, patients with Medicare Advantage are discharging from their home health services with less functional independence, and that can kind of translate into more, caregiver burden in addition. But it's also concerning because patients with these plans with Medicare Advantage, they are more likely to live alone and have less support to begin with. So they're really relying on these improvements in function even more. And providers have really been kind of sounding the alarm about some of these restrictions in care and delays in care and burdensome administrative processes under Medicare Advantage for years. But really depending on which outcomes you use or how you set up some of the comparisons, we're not always seeing these challenges reflected in the patient outcomes, especially if you're only looking at differences in costs or readmissions that are, maybe more important to the payer, but less pertinent to the patient. So I see this as sort of a sign that the health system, the providers, we've been sort of absorbing the bulk of the administrative burdens for some time. But now that we're starting to see a really overstretched health system, a lot of staffing challenges, we are starting to see some of the differences in care outcomes that are trickling down to the patient because of how challenging it can be administratively to provide care to patients with Medicare Advantage plans.
It's a lot to think about there as we think about the future of the Medicare program and the role of Medicare Advantage. At the end of our podcast interviews, we like to ask a couple questions of our guest authors, and I'll pose the first one to you. What's the best advice you've been given about your career, particularly for developing policy-relevant work, such as your article in JAMA Health Forum on home health services in Medicare?
I have a clinical background, like you, John. I was a physical therapist before I went back for another degree to become more of a health systems and policy researcher. But in the health policy space in particular, I think it can be a bit intimidating for a clinician to kind of be thrust into this world of health economists and statisticians and policymakers who speak a little bit of a different language around some of these incentives and financial structures. But very early on, I was reminded that the clinical perspective and the clinical experiences are really what are driving the research questions in post-acute care, and they're really what the policy is created about. So I was really counseled not to lose sight of the fact that I can always learn the methods, but to not undersell the importance of the clinical perspective. And I think especially as rehab providers, as therapists, we might not always have a seat at the table in some of these broader health policy discussions, even in post-acute care where we provide the majority of the services. So I'm grateful for the funder of this study too, who learned because they're really trying to help elevate rehab providers as policy researchers and help address some health systems prioritized questions.
Yeah, thanks. You bring a fresh perspective to these important research questions.
Thanks.
Yes. And I would love to know your fresh perspective on our final question, which is, what is the biggest change you expect over the next 5 years related to health policy in general or to Medicare and home health services specifically?
This particular question on Medicare Advantage and home health, it's really a very small part of a groundswell of research that is attempting to understand the massive implications of this huge increase in Medicare Advantage enrollment. As you know, we surpassed 50% enrollment for the Medicare population and in Medicare Advantage plans. So what does it now mean that private insurance is dominating the Medicare market? And how is that going to impact not only the financial health of the Medicare program, but what does it mean for patients? So I think we're going to continue to see more and more research, obviously, but we're also seeing some pretty unprecedented attention under the Biden administration to Medicare Advantage. So I think that's another big thing that's going to continue as we see some pushback against potential upcoding and some of these restrictions on coverage criteria that I spoke about. But, really Medicare has an uphill battle. These are very popular plans, and rightfully so for a lot of folks as they enroll in Medicare, as, they're maybe younger and healthier. And us in rehab, we start seeing some of the back end challenges, but it's a huge system. It's a popular system. There are over 4,000 different Medicare Advantage plans. And so I think regulating them is going to be a very big challenge. And we're going to continue to see different methods trying to come out to see if we can make sure that patients are receiving the care that they're entitled to. So I'm hopeful that we continue to also see more research that's patient-centered, that's looking at outcomes that matter to patients in their day-to-day lives, and to really include some of these more social and environmental risk factors that patients are experiencing.
Thanks to our guest author, Dr. Rachel Prusynski at the University of Washington. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.